Good afternoon, everybody. Last two classes we discussed about the higher mental functions, the cranial nerve examination. In the first class, we discussed about general physical examination and higher mental function. In the second class, we discussed about the cranial nerves. The first cranial nerve, olfactory nerve, optic nerve, then the third nerve, fourth nerve, sixth nerve, and trigeminal nerve. Today, in the day 3, we will discuss about the important cranial nerve, 7th, 8th, and the other cranial nerves. Okay, so first let us come to the cranial nerve 7, that is the facial nerve. Okay, so before going to the examination of the facial nerve, you should know a detail of the course of the facial nerve and anatomy of the facial nerve. Okay, so first let us go to the anatomy of the facial nerve. So the components of facial nerve. Okay, so what are the components of facial nerve? See here, the facial nerve nucleus, this is the facial motor nucleus. It is situated here in the pons, the facial motor nucleus. Okay, and here is the abducent nerve nucleus. Okay, and here there is a superior salivatory nucleus which supplies to the submandibular and sublingual salivary glands and the lacrimal nuclei. Okay, right. So the facial motor nucleus will take a turn around the abducent nucleus. It goes and take a turn around the abducent nucleus, and this is the motor route. You can see here, this is the motor route. It takes a turn around the abducent nucleus. Now the fibers from the superior salivatory nucleus and lacrimal nucleus, okay, join with the fibers from the nucleus of the tractus solitarius. You can see here the solitary nucleus of the tractus solitarius. This nucleus contains the fibers of the chorda tympani, which supplies to the anterior 2/3 of the tongue, which carries the special sensation, okay, that is the taste sensation, and also the posterior 1/3 of the tongue, which is glossopharyngeal nerve. Okay, so this nucleus of tractus solitarius contains those fibers. So fibers of the nucleus of the tractus solitarius along with the superior salivatory and the lacrimal nucleus, they join together, okay, to form nervus intermedius. Okay, they join together to form the nervus intermedius, and then they go through the geniculate ganglia, which is the ganglia of the facial nerve. So I repeat again, there is a motor nucleus, facial and motor nucleus. It bends around the 6th nerve, and then it comes here out of the pons as a motor route. And then you have superior salivatory and lacrimal nuclei along with the fibers from the tractus solitarius, joins as a nervus intermedius, and then through the geniculate ganglia it comes out. Okay, right. Now what happens afterwards? Then again I'll go back, I'll go front and tell the course of facial nerve. Okay, see here in this course of facial nerve you can see the 3 components mainly in this diagram. See this unbroken line, this is the unbroken line. Okay, this unbroken line is from the motor nucleus of the 7th nerve. It is the motor nucleus of the 7th nerve facial nerve. It's unbroken line. Okay, so this unbroken line winds around the nucleus of the 6th nerve. See here, the motor route winds around the nucleus of the 6th nerve. Okay, and then it gives terminal facial nerve branches, okay, which supplies the muscles of the face, that is the digastric, stylohyoid, temporofacial, craniofacial nerves. Okay, this is the motor route from the motor nucleus of the facial nerve. And here you can see broken lines. There are 2 broken lines. One is a large broken line, okay, large broken line, and another is a small broken line. Okay, small broken line you can see are 2 things. One is from the lacrimal gland here, small broken line, and another from the sublingual and the submandibular gland, small broken line. Okay, where are these fibers are coming from? Okay, you can see here there is superior salivatory nuclei. Superior salivatory nuclei, okay, it supplies okay, through the nervus intermedius. Okay, through the nervus intermedius. Here you can see the greater superficial petrosal nerve. The greater superficial petrosal nerve through the sphenopalatine ganglion, it supplies the lacrimal gland. Okay, that is one. Superior salivatory nucleus supplies to the greater superficial petrosal nerve through the sphenopalatine ganglion to the lacrimal gland, and also the some fibers from the superior salivatory nucleus through the nervus intermedius, it supplies here, okay, the submaxillary and submandibular glands. Okay, submaxillary and sublingual glands. Okay, submaxillary and sublingual glands. Okay, this is a small broken line. from the superior salivary nucleus. Okay. Now you can see a large broken line. The large broken line here you can make out. See, there is a large broken line. Okay. So this large broken line, these are the fibers from the nucleus of the tractus solitarius. So where is here? See, nucleus of the tractus solitarius. Nucleus of the tractus solitarius is here. You can see here the large broken line. Okay. Through the chorda tympani, it supplies the anterior 2/3 of the tongue, supplying the taste sensation. Okay, these are the course and branches. So to summarize, you have a motor nucleus, winds on the sixth nerve, supplies the muscles to the face. You have a superior salivary nucleus, it supplies to lacrimal gland, sublingual, submaxillary gland. Lacrimal gland, it supplies to greater superficial petrosal nerve through the spinopalatal ganglia, supplies the lacrimal gland, whereas for the sublingual and submaxillary gland through the lingual nerve it supplies. Okay, lingual nerve it supplies. Okay, and also chorda tympani branch is the special sensation to the tongue. These fibers are from the nucleus of the tractus solitarius. Understood? There are three things: superior salivary, tractus solitarius, and motor nucleus. So this you should know. We'll come back to this again while localizing the facial nerve pathology, where to localize what disease patient will be having. Okay. Now we'll just go to the examination of the facial nerve examination. How to examine the motor system examination of the facial muscle supply of the facial nerve, and how to examine the sensory supply of the facial nerve. Okay. Now we have examined how to look for the motor part of the facial nerve and also the sensory part of the facial nerve. Okay. Now how to distinguish a element facial nerve palsy from a human facial nerve palsy? What are the differences? See, element facial nerve palsy, the upper part will be affected. Upper part will be affected. The frontal belly of occipitofrontalis won't produce any furrows while examining the patient, which we seen. Okay, while examining the patient in the low element facial palsy. They have epiphora because the eyelids cannot hold the lacrimal secretion. They have epiphora from the eyes. One important thing in element facial nerve palsy is Bell's phenomena. Okay, Bell's phenomena. So normal person, when they try to close the eyes, the eyelids will roll over. Okay, but because the eyeballs will roll over, but because eyelid cover there, we cannot see any sclera, lower part of the sclera. But in Bell's phenomena, because they cannot close the eyes properly, lag ophthalmos is there. When the eyelid turn upwards, you can see the lower part of the sclera. That is known as Bell's phenomena. Okay. So element facial nerve palsy, whole face will be affected, upper part and lower part, and Bell's phenomena will be there, and there will be epiphora. One more bedside clinical test to detect the element facial nerve palsy is normally when the patient tries to close the eyes, if you just put your finger, thumb or the index finger, you can feel the vibration experienced by the when the patient closes the eyes, you can feel the fine vibration. That vibration you won't feel if there is an element facial nerve palsy. Okay. Now, what are the difference between bilateral element facial nerve palsy and bilateral human facial nerve palsy? This is a very tricky situation where both the sides there is human and bilateral element. What is the differences? So in a bilateral human facial nerve palsy, jaw jerk will be exaggerated. Okay, and emotional fibers won't be affected. Emotional fibers will be affected in element facial nerve palsy. I'll tell next what is the difference of volitional facial nerve palsy and emotional facial nerve palsy. Jaw jerk will be exaggerated. Emotional fibers won't be involved in human nerve facial nerve palsy. Corneal reflex will be present. Okay, and long tract signs will be there in human facial nerve palsy. As in element facial nerve palsy, Bell's phenomena will be there. Emotional fibers will be affected and corneal reflex will be affected in a element facial nerve palsy. Now, what are the cause of bilateral element facial nerve palsy? The causes of bilateral element facial nerve palsy and diabetes can produce, Guillain-Barré syndrome, motor neuron disease, bulbar palsy, Lyme's disease, meningitis, Melkerson-Rosenthal syndrome, leprosy. Okay, so there are a huge list of causes, sarcoidosis. Okay, these are the causes of bilateral element facial nerve palsy. Now, What is a dissociation of the facial nerve palsy? See, this dissociation of the facial nerve palsy you get only in a human facial nerve palsy, upper motor nerve facial nerve palsy. The facial nerve nuclei in the brainstem, it has connection from the precentral cortex, it has connection from the frontal lobe. Okay, this frontal lobe connection to the facial nuclei, it helps in only during emotional time, whereas the precentral center from the cortex. So what is dissociation facial nerve palsy? You see, the nucleus of the facial nerve in the pons has connection from the frontal lobe and also from the precentral lobe. Okay, the frontal lobe connection helps during emotions, whereas the precentral connection helps during volitional. What do you understand by that? For example, if the patient while laughing, while crying, if there is a facial nerve weakness, it is known as emotional facial nerve weakness or a mimetic facial nerve weakness, mimetic facial nerve palsy. That you get in frontal lobe infarction, frontal lobe affection. Whereas volitional, that you get in a whenever there is a precentral cortex is damaged, the fibers which carry to the facial nerve nucleus are damaged. So volitional facial nerve palsy means when you ask a patient to show the teeth, to close the eyes, at that time there may be a weakness, that is known as volitional facial nerve weakness. This is dissociation, emotional and volitional facial nerve weakness you see in the upper motor neuron lesions, not in a low motor neuron lesions, because low motor neuron contains all the fibers. So this dissociation won't be there. Okay, right. So now next coming to the some of the aberrant connections problems with the facial nerve, which you already discussed while discussing about the trigeminal nerve and the third nerve. Okay, there is inverse Marcus Gunn phenomena, jaw winking phenomena, inverse Marcus Gunn jaw winking phenomena. Okay, and also known as Marin-Amott syndrome. So what happens here? As I told, the fifth nerve will be connected aberrantly to the seventh nerve. Whenever the patient jaw moves, okay, at that time the eyelid will close because of orbicularis ocular muscle action. This inverse jaw winking phenomena or Marin-Amott syndrome. The one more aberrant connection problem with the facial nerve is, okay, the crocodile tear syndrome. Here what happens is there is aberrant connection between the salivary glands and the lacrimal glands. Whenever the patient eats the food, at that time due to the aberrant connections, there will be a eyelid will be filled with the tears. This is crocodile tears. Okay, now let us localize the lesion in the facial nerve. Okay, from the nucleus till the periphery. What are all the causes? How do you identify clinically the localization? Now, for example, here if the nucleus is affected, the motor nucleus of the fifth nerve in the pons, there won't be any associated signs because only the nucleus will be involved. They will have fasciculations because the nucleus is involved in the facial muscles. The disease which produces this nuclear involvement is motor neuron disease and Mobius syndrome. Mobius syndrome is congenital absence of seventh nerve and sixth nerve. Motor neuron disease, the motor nucleus of the facial nerve will be involved. Okay, this is a nuclear involvement. Now coming to the pontine here, this is the pons, okay, in the pontine region. In this region, suppose if there is any facial nerve weakness, what happens? You will get a cross hemiplegias. What is the syndrome? The facial nerve weakness, ipsilateral facial nerve weakness, contralateral hemiplegia, the Millard-Gubler syndrome you will get here if there is affection in the pons, or even you can get Fovili syndrome, okay. Along with the seventh nerve palsy, there is a lateral gaze palsy, okay, in the Fovili syndrome with contralateral hemiplegia. What are the diseases which will affect when it is in the intrapontine regions? Here, the diseases which will affect in the intrapontine regions are any infarction, hemorrhage, there can be a tumor or a demyelination. Okay, demyelination, infarction, hemorrhage or meningitis, okay, producing vasculitis and infarction, okay, can affect the intrapontine regions. Now, next coming to the CP angle, the junction, a CP angle junction, okay, the CP angle junction, okay, the patient will have other cranial nerve involvement like the eighth nerve involvement in the form of deafness or tinnitus, and cerebellar affection will be there, so patient will have ataxia, okay. And here one more thing, in the intrapontine region there won't be any taste abnormality, but plus or minus lacrimation affected or hyperacusis. Plus or minus lacrimation or hyperacusis. Whereas if it is involved in the CP angle junction, there will be lacrimation will be affected, there will be hyperacusis because stapedius, nerve to stapedius will be involved, and loss of taste sensation because nerve to chorda tympani will be affected. Okay, in CP angle junction. What are the diseases which produce the CP angle junction tumors? Acoustic neuroma, cholesteatoma, meningiomas, tuberculomas can produce a CP angle mass-like lesion. Okay, producing all these clinical features in the facial nerve. Now, next coming to the facial canal. Okay, in the facial canal, geniculate ganglia. Okay, the geniculate ganglia you have is the facial nerve ganglion. Okay, in the geniculate ganglia, if the problem is there, they'll have lacrimation affection, the sublingual gland, the salivary gland will be affected, and also the nerve to stapedius will be affected, and chorda tympani will be affected. Okay, so there will be lacrimation problem, taste sensation problem. Okay, and also they will have problem with the salivation. That is the geniculate ganglia. What are the diseases which will affect the geniculate ganglia? Okay, Ramsay syndrome is the one disease which affects the geniculate ganglia, and Bell's palsy, Guillain-Barré syndrome, HIV. Okay, so next in the facial canal between the geniculate ganglia and nerve to stapedius. Okay, if that area is affected, the lacrimation will be spared, only there will be hyperacusis, the loss of taste sensation will be there. From the nerve to chorda tympani to the nerve to stapedius, if there is a problem, there won't be any hyperacusis, only there will be a problem with the taste sensation. Suppose if the lesion is after giving the chorda tympani, okay, there won't be even any taste involvement, won't be there. There won't be any hyperacusis, there won't be any lacrimation problem. Okay, suppose if the lesion is stylomastoid foramen, just in the facial canal above the stylomastoid foramen, like in the Bell's palsy, everything will be spared. Okay, patient will have a facial nerve weakness. Okay, only if the Bell's palsy, if the lesion is above the stylomastoid foramen affecting the chorda tympani, taste will be affected. Okay, so these are, I will repeat again, motor nucleus of the seventh nerve. If the nucleus is affected here, motor nucleus of the seventh nerve is affected here, MND. Okay, Mobius syndrome. These are the two diseases in the motor nucleus of the seventh nerve. Then in the intrapontine regions, strokes, multiple sclerosis, tumors can be affected. Then in the geniculate ganglia, Ramsay syndrome, Bell's palsy, Guillain-Barré syndrome, HIV, okay, those things will be affected. And then in the facial canal, from geniculate ganglia till the stylomastoid foramen, the etiology is same only. Whatever the etiologies I told in geniculate ganglia, same etiologies will be there, like Bell's palsy, Ramsay syndrome, Guillain-Barré syndrome, HIV, those diseases will be affecting the facial nerve from here to here. Okay, so this is about the localization of the facial nerve. Now let's come into the two important things. One is the Ramsay syndrome, another is the Bell's palsy. The Bell's palsy, the problem is in the just above the stylomastoid foramen. Okay, this is element facial nerve palsy due to herpes simplex virus. So depending upon the level of extension of the lesion, patient may have the taste disturbance or may not have. Okay, may not have. Diabetes and hypertension is the risk factors. 20 to 30% of the patients will have diabetes and hypertension in Bell's palsy. What are the poor prognostic factors in Bell's palsy? If the age is more than 60 years, if there is an involvement of the taste sensation, if there is a lacrimation is affected, or if there is hyperacusis, or if there is diabetes and hypertension in Bell's palsy, it is a very poor prognosis. So another thing is Ramsay syndrome. In Ramsay syndrome, it is a geniculate ganglia affection of the herpes. Okay, they will have vesicles in the external auditory canal and tympanic membrane. There are two types, otologic form and prosopologic form. In otologic form, there will be pain around the ear. In a prosopologic form, there will be pain around the face, palate, and all will be there. And Ramsay syndrome sometimes can be associated with the eighth nerve. I'll tell all my students on homework, What are the other entities in the CNS which are given the name Ramsay syndrome? So this is not the only one Ramsay syndrome. So just for your curiosity, you can go and check, okay, what are the other diseases which are named as Ramsay syndrome in CNS. So the mainly the pathway of the facial nerve and localization from the nucleus here, okay, then intrapontine region, then CP angle junction, geniculate ganglia, facial canal. Facial canal, geniculate ganglia includes in facial canal, and then nerve to stapedius, greater petrosal nerve to stapedius, nerve to cardiac tympanic. So at 3 levels, how to localize depending upon their clinical features. So simple. So anatomy is so essential. If you know the anatomy, then you can localize, and the diseases also you can enumerate. What are the diseases it produces at specific lesions? Okay, viewers, this is about the facial nerve. Dear students, now let us go how to examine the facial nerve. The anatomy of the facial nerve and the course and distribution I have discussed in the theory. Now let us go how to examine the facial nerve. Which are the muscles supplied by facial nerve? Frontal belly of occipitofrontalis, orbicularis oculi, buccinator, orbicularis oris, platysma. There are other 2-3 muscles which are supplied by facial nerve which you cannot test clinically. Stylohyoid, posterior belly of digastric. Okay, and some of the ear muscles cannot be tested clinically. Now I will show how to examine the motor part. Later we will go to the sensory system examination of the facial nerve. ये आंख का ये part है ना ऊपर करना. Yeah, she is able to do that. Then you can see the furrows. ऊपर कर कर वहाँ ही रखना. You can see the furrows here, students. ठीक है. मेरा उंगली देखना. ऊपर. See, you can see the furrows. This is a frontal belly of occipitofrontalis. Next is orbicularis oculi. आंख को full tight बंद करना. You try to open it. However strong you are, you won't be able to open. Okay, if orbicularis oculi is normal. Then nasolabial furrow. If there is ipsilateral facial nerve weakness, that side nasolabial furrow won't be prominent. Next is buccinator. Is that See, I am not unable to blow the tongue out. He is holding the air inside the cheek. So I am not able to blow it out. The buccinator is normal. Next is orbicularis oris. Couple whistle karo. Yeah, this is orbicularis oris. Next is platysma. Aisa karo. Eversion of the lower lips will produce platysma prominent. Eversion of the lower lips. Okay, ठीक है. Leave. Suppose if there is a ipsilateral facial nerve weakness, the food will stay there only and there will be drooling of saliva from that side. Okay, right. How do you distinguish a UMN facial nerve palsy from a LMN facial nerve palsy? The upper part will be affected in LMN facial nerve palsy. Upper part will be spared in UMN facial nerve palsy because of bilateral representation. So they will have epiphora, eye will be involved and Bell's phenomena will be there. Bell's phenomena is normally when the person closes the eyes, the eyeballs will roll up, the lower part of the sclera won't be visible due to the eyelid will close. Whenever there is a facial nerve weakness, the eyelids cannot close properly, so the lower part of the sclera can be visible. That is Bell's phenomena, is a feature of LMN facial nerve palsy. What are the differences between bilateral LMN facial nerve palsy and bilateral UMN facial nerve palsy? So Bell's phenomena is a feature of bilateral LMN. Emotional fibers will be affected in LMN facial nerve palsy. I will discuss that later, what is volitional and what is emotional or mimetic facial nerve palsy. Jaw jerk will be exaggerated in bilateral UMN facial nerve palsy and there will be associated long tract signs in bilateral UMN facial nerve palsy. Corneal reflex will be absent in LMN facial nerve palsy, bilateral LMN facial nerve palsy. Okay, now I want to tell some of the conditions where there is a bilateral element facial nerve palsy. You're getting diabetes mellitus, Guillain-Barré syndrome, leprosy, leukemia, lymphomas, sarcoidosis, motor neuron disease, myasthenia gravis, Melkerson-Rosenthal syndrome. Diabetes, Guillain-Barré syndrome, Melkerson-Rosenthal syndrome, leukemia, lymphoma, leprosy, motor neuron disease. You get bilateral element facial nerve palsy. Now, I'll go to examine, I'll tell briefly about the examination of the sensory part of facial nerve, and then we'll try to localize the facial nerve weakness. The taste sensation anterior two-third is by cardiac tympani. Okay. Superior salivatory nucleus of the facial nerve supplies it. The taste sensation which are tested are salt, sour, bitter, sweet. Of late, a new thing has been added, umami, which is a delicious. Bitter should be the last to test because it leaves some taste abnormality in the tongue, so it has to be last to be tested. Patient should close the eyes, put the tongue outside throughout the examination. In between the different tests, he should rinse with the water. Then each side should be tested separately. The taste particle should be put between the middle third and anterior one third, and that area you have to put it. Okay. So this is how some important points in taste examination of the facial nerve examination. Now I just want to localize it by putting the anatomy and how you can localize a facial nerve problem. Before that, I want to tell what is dissociation of the facial nerve weakness, mimetic facial nerve palsy and volitional facial nerve palsy. Volitional means while you tell the patient to do that act, at that time only there will be a weakness, but not emotionally when he is laughing, when he is crying, at that time there won't be any weakness. Volitional facial nerve weakness you see in a precentral cortex problems, whereas emotional problems, mimetic facial nerve palsy, you see if there is a problem with the frontal lobe. At that time, whenever he laughs, cries, at that time there will be a facial nerve weakness. Not during when you tell the patient to do the action. That is mimetic or emotional facial nerve palsy. This dissociation of the volitional and mimetic facial nerve palsy is a feature of UMN. In LMN, both the emotional and volitional fibers will be affected. Now, briefly about the anatomy and localization of the facial nerve weakness. You have three nucleus. One is a motor nucleus of the facial nerve, superior salivatory nucleus which supplies to the lacrimal gland, submandibular and sublingual salivary glands, nucleus of tractus solitarius which supplies to the anterior two-third of the tongue, the taste sensation. Fibers from the nucleus tractus solitarius and fibers from the superior salivatory nucleus join together to form nervus intermedius. Then they go through the geniculate ganglion. From the geniculate ganglion, greater superficial petrosal nerve supplies the lacrimal gland. Then after the geniculate ganglia, you will have nerve to stapedius. Then you have nerve to cardiac tympani. Then the nerve emerges from stylomastoid foramen and supplies the muscles of the face, temporal, zygomatic, buccal, maxillary and cervical. Branches it supplies the muscles of the face. Now how to localize the facial nerve weakness depending upon the etiology and anatomical localization. Suppose if there is a nuclear problem, there won't be any other associated signs, only facial nerve weakness will be there. The etiologies are motor neuron disease and Mobius syndrome, where there is a congenital absence of 7th nerve and 6th nerve palsy. If it is the intrapontine, from the nucleus to the pons where it is coming out of the brain, if it is the intrapontine, then you will have ipsilateral facial nerve weakness, contralateral hemiplegia, Millard-Gubler syndrome, or Fovey syndrome, ipsilateral 7th nerve palsy with horizontal gaze palsy plus contralateral hemiplegia, that is Fovey syndrome. Here, taste sensation is not affected. There may or may not be hyperacusis and lacrimation may or may not be affected. So, lacrimation and hyperacusis may or may not be affected in intrapontine lesions. What are the diseases which affect the intrapontine lesions? It can be a vascular, can be hemorrhage, tumor, demyelinating lesions. Tumor, demyelinating lesions are ischemic lesions in the intrapontine lesions. Next is CP angle junction acoustic neuroma. In the CP angle junction acoustic neuroma, they will have all the problems, lacrimation, hyperacusis, taste sensation, everything will be affected. Along with that, eighth nerve symptoms like deafness, cerebellar problems will be there because of cerebellar tracts will be affected. If the compression is severe, they will have fifth nerve, along with that ninth and tenth also. So, what are the diseases which affect the CP angle junction? Cholesteatoma, CP angle tumor, acoustic neuroma, tuberculoma, or meningeal granulomas at that CP angle junction. After CP angle junction, once you come to facial canal, in the facial canal, you have a geniculate ganglia. If geniculate ganglia is affected, so they will have lacrimation problem, hyperacusis, taste sensation, everything will be affected. What is the disease which affects the geniculate ganglia? There can be a basilar fracture trauma producing battle sign and raccoon sign, Guillain-Barré syndrome, diabetes, HIV, Lyme's disease, tumor. These all can affect Bell's palsy, Ramsay syndrome. These are the diseases which affects in the geniculate ganglia. Next, in the facial canal, from the geniculate ganglia to the nerve to stapedius. Here, there won't be any lacrimation problem because the greater superficial petrosal nerve has been given already. Nerve to stapedius will be problem, so they will have hyperacusis and taste will be affected. Then in the facial canal between nerve to stapedius and chorda tympani, here there won't be any hyperacusis because nerve to stapedius is above, only taste sensation will be affected. Then below the chorda tympani, even taste won't be affected, only facial muscles will be affected. The etiologies in the facial canal are same as like etiologies for the geniculate ganglia like Guillain-Barré, diabetes, HIV, Lyme's disease, Ramsay syndrome, Bell's palsy. Just a few points about Ramsay syndrome. Ramsay syndrome, there are two types, otologic form and prosopologic form. Otologic form, they will have a pain behind the ear and vesicles in the external tympanic membrane. Prosopologic form, they will have pain in the pharynx, head and face. Just for curiosity, students, a homework will be given to you. You find which are the other conditions where Ramsay syndrome name is applied in CNS apart from this condition. In Ramsay syndrome, even there can be associated eighth nerve palsy also. Bell's palsy, there is a stylomastoid foramen just above it is a affection of the facial nerve due to the herpes simplex virus. It is an element facial nerve palsy. Depending upon the extent of lesion, there can be a taste involvement, hyperacusis or lacrimation may be involved. Age more than 60 years, if taste, lacrimation and hyperacusis is there or associated diabetes and hypertension, then there is a grave prognosis in a Bell's palsy. So, this is about examination of the facial nerve, anatomical localization and how to interpret the localization, Ramsay syndrome and Bell's palsy. Students, I just want to tell some points about the facial nerve examination. Okay, you have to ask the patient to show his teeth, so whichever side the angle deviates, that is the normal side. As I already explained you, the face will deviate towards the normal side in facial nerve examination. And you have to ask the patient to close the eyes tightly and you have to palpate with your index finger or the thumb finger. You will feel the fine vibration if the muscle is normal, if the upper part of the face is normal. This is known as Bergera-Wartenberg sign. Bergera-Wartenberg sign. If that is lost, then that is a element facial nerve palsy. And I told you about the pathway of the facial nerve palsy, how to localize it. And the two syndromes where you get in the intrapontine lesions is Willard-Gubler syndrome and Foville syndrome. Ipsilateral facial nerve palsy, contralateral hemiplegia. Foville syndrome is ipsilateral 7th nerve palsy, ipsilateral 6th nerve palsy with contralateral hemiplegia. And one more point about Ramsay syndrome is it is a herpes zoster infection of the geniculate ganglia. You will have the external auditory canal and tympanic membrane vesicles. But some patients there will not be vesicles in spite of herpes zoster infection of the geniculate ganglia only with the facial nerve paralysis. That is known as zoster. And I already given the homework Ramsay syndrome, which are the condition it is used. Just a few points I wanted to add, students. Thank you.